Hello, everyone. Last talk of the day. It's hard to go up against Dean, isn't it? The nicest man in myeloma. His beloved Nottingham Forest also got a 4-point penalty this week. Last night, he got to his hotel at 1 a.m. and there were no rooms. He spent all night at King's Cross Station, and I still have to do this to him. But the short answer is no, we should not. So before we get there, just humour me for a minute. I'm going to talk about Marshall Mathers, also known as Slim Shady. So this is the Slim Crab. So before we talk about... I'm glad, actually, someone's actually appreciated that. I thought there'd be complete silence. He actually turned 50 this year, which actually makes me feel very old. But that's not really the point of this talk. But so before we get to high-risk smoldering myeloma, well, what about Slim Crab? It's been 10 years since the IWMG told us that Slim needed to be treated. But also, how well has Slim actually aged? Terribly. I think, as we all know, and as you all see in your clinics, this was a nice meta-analysis by Ludwig and colleagues from last year. And just very briefly, top-line analysis is that, and we know this, that people who have light chain ratios greater than 100, or even heavy marrow infiltration, they progress a lot more slowly than we thought they were going to, and patients clearly have been overtreated. So what I'm telling you is that you don't even treat all your patients with symptomatic multiple myeloma, so why would you treat high-risk smoldering myeloma? I rest my case. So the first thing I'm going to say is, okay, we're talking about high-risk smoldering multiple myeloma, but what is it? And I would argue that we don't really understand what it is. Now, there are a number of models. Dean showed us the IWMG model. This is on the left panel is actually the Mayo 2020 model, which looks at 3 specific criteria, paraprotein, bone marrow infiltration, and light chain ratio greater than 20, and you get a separation of 3 curves. But as you can see, there's still plenty of patients that are even high risk who have not progressed at 5 years. The Spanish classification is older, using immune paresis and phenotypically abnormal plasma cells. And again, you have 3 groups. But as you can see, that even in patients that are shown to be intermediate or higher risk, there are a significant proportion of patients who haven't progressed at 5 years. And the problem is that there is very poor concordance between these different models. Now, this is from JAMA Oncology in 2021, essentially just looking at 3 risk stratification models, the Spanish PETHEMA model, the Mayo 2008, which is similar to the 2018, but you have to have a lower bone marrow infiltration, and the light chain ratio levels are slightly different as well. But as you can see, there is very little concordance when you look at low, intermediate, and high, and that's on the left-hand panel. And even if you just separate non-high risk and high risk, there's very little concordance on what a high-risk group actually is. More recently, the Dana-Faber have come up with the Pangea models, and there's a nice calculator on the internet where you can put in various bits of data, which is generally easily obtainable, some which have bone marrow in, some which have fish in, and there is lots of information showing us now that actually the rate of what looks like low, intermediate, and high is very different depending on what model you are putting your patients into. So I think a really important point to make is like, should we treat high-risk smoldering multiple myeloma? I would argue that there isn't any clear guidance on that we really understand what high-risk smoldering multiple myeloma is. But if we have a defined group that we're going to treat, then, well, what do we need to see? These patients are asymptomatic by definition. So clearly there are nuances in the way we're thinking about treating these patients, but clearly if you're asymptomatic, and I'm not discounting the psychological morbidity that Dean touched on, but you have to show that people live longer than the standard of care. And I'm going to argue that that standard of care should still be observation, and you should see an overall survival benefit. We're not talking about patients that are symptomatic and need to have treatment where we can think about surrogate markers, whether it be PFS or MRD. I think overall survival has to be the metric that we look at. Is it safe? You're going to have less side effects on no treatment, and some side effects can unfortunately be very, very significant. If you treat the disease earlier, is there any evidence that anyone can show me that you're making it inherently more treatable? I think Dean correctly touched on the fact that if you are treating at earlier stages, maybe it is inherently more treatable. If you could convince me that actually by treating smoldering myeloma, you're going to get everyone to a very deep MRD negative CR, which is sustained, well, that's interesting, isn't it, potentially? Or do you affect the natural history in a positive way? By immune modulation, do you change clonal evolution? Do you change other aspects? Are they less likely to get bone disease? These things would be important, and if there is evidence that that happens, then that is interesting and worth looking at. Are you going to improve quality of life? These patients are asymptomatic, but I would counter that, yes, psychological morbidity is important. In other disease areas, a number of you will remember the rituximab versus observation watch and wait study in follicular lymphoma. That study showed that by giving patients rituximab, you reduced psychological morbidity, and that was very nicely documented in the Lancet paper from around 10 years ago now, and that is some decent evidence in an allied disease area. End organ damage. We spend a lot of time thinking about it. Of course we do, because it's important. But are we confident that prevention of end organ damage is irreversible and morbid? Not all end organ damage is created equal, and some are more reversible than others. So I've got a couple of slides on the two studies that Dean presented, the Quiridex study and also the American study from 2020. A couple of points to make. The Quiridex study on the left there, 10 years old now, so no patients in that study had modern imaging techniques. You only had to have skeletal surveys to get in, so we really don't know how many of these patients actually had symptomatic disease that needed standard sorts of treatment. The study also wasn't powered to look at overall survival, and the numbers in each arm were small. So I think certainly 10 years on, I don't think we can really look at that study, and I don't think it helps the argument of treating early. With overall survival as the metric that I argue that we need, the bottom panel there on the right is the overall survival curve in the Len versus observation study from the States. As you can see, it's completely overlapping. I think that is important. I think what is also extremely important, this is the patient disposition in this study. And just look at how many low-risk patients there are in the study and how many intermediate-risk patients there are in the study, based on both the Mayo 2008 and 2018 criteria. I've just put the criteria below the patients, but there are a significant majority of patients that would have not progressed 5-6 years, for a minimum of 5 to 6 years. These are not high-risk patients in any way, and as actually they are open in the study, they had to change the inclusion criteria to actually get the study recruited. So this is not a study of high-risk smoldering multiple myeloma. Okay, so if you're going to treat it, then, well, is it safe and what are the risks? So this is the Spanish study, the GEM-CAESAR study, which was initially presented at ASH, I think a couple of years ago, and this was a curative approach. So this isn't the type of more nuanced approach that Dean was alluding to. This was, we're going to treat it early, we're going to treat it hard. So a standard kind of induction approach with a triplet this time, transplant and then consolidation and maintenance. And this is a lot of treatment, but after quite a lot of treatment, if you look at how well people have done, yes, there is a significant amount of MRD negativity after defined time points. But when you look at this and compare this to other studies where patients have needed to start treatment for symptomatic disease, it doesn't really look that different. So it's very similar to Forte, for example, which is a similar sort of approach, KCD or KRD, followed by a similar sort of transplant consolidation and maintenance strategy. So I don't think you can argue that treating it earlier makes it inherently more treatable on the data that is out there. And of course, well, people died on this study, and I'm not going to start sort of saying carfilzomib is a terrible or toxic drug, but we all know the toxicities of combinations of drugs that we all use. And I think my point about this slide mainly is that, well, there's no control group. Patients die in control groups, patients get heart attacks and all sorts of problems in control groups. And there are lots of big studies, again, in similar disease areas. The Germans did ibrutinib versus placebo for asymptomatic CLL. And you could actually have a meaningful discussion about toxicity because patients died in the observation arm as well, and there were AEs in the observation arm. Clearly, you look at some of these toxicities, and you think they're probably partly related to some of the drugs that were given, clearly. And this is from a starting point of a patient basically having no symptoms at all. Okay, so what about end organ damage? So not all end organ damage is created equal, and I think this is a really nice study. This is being run in the States by a few centers, and essentially what they're trying to understand is who gets morbid end organ damage, and they're looking at that by basically doing an observational study with lots of imaging, bone marrows, and understanding is like who are those patients that really get end organ damage that is not reversible. So I think this is an area that has been poorly investigated so far, and I think this will certainly add to the discussion. So, in summary, you don't even treat all patients based on SLIM before we even get to high-risk smoldering multiple myeloma. We can't agree on what the disease actually is, and I think a lot of progress is being made with all the biological and profiling studies that are being done in this space. There is no appropriately sized study showing an overall survival benefit against observation that has a better population that we would think is definitely not low risk. Recent trials haven't shown that smoldering myeloma is more inherently treatable, and people have died on these studies. Could end organ damage be avoided? Not always, for sure, but I think there is research being done to try and understand if we can better characterize how this can be done. And I think this is a reasonable point that pushing the can down the road is helpful. Now during induction, we're giving patients, of course, quadruplets and maintenance with transplant, and we know that when standard risk patients progress in 4 or 5 years, the landscape's going to look very different to them. It's a similar potential argument with smoldering myeloma as well. This doesn't come out very well, but this is from Blood. There's a very nice article just from a couple of weeks ago, just an observation about a number of these points. So I would encourage you to have a read. And that's it. Thank you.